Our next speaker is someone else who hasn't been idle in his life. I don't think I could sit and talk to him, with him, listen to him for hours. Dr. Nick Reed describes himself as a gastroenterologist, nutritionist and psychotherapist. He's had a long academic career. He's currently now retired from the university and the NHS, but he still writes, gives lectures and has a private practice in psychotherapy. And his main role is in supporting the IBS network. I like the comment at the end of his bio, which says he's a dedicated advocate of self-care, which is something we are all going to have to do far more of. He has an infinite curiosity, which I think keeps our brains alive. And, you know, what worse than to be not interested in anything anymore. I'm not sure I'd join you in the curiosity about swimming in cold water. You can keep that, though. Dr. Reed.
That's great. Thank you very much. Well, good morning, ladies and gentlemen. It's nice to be here, and thank you, Linda, for the invitation. I'm going to talk rather rapidly about self-management in IBS. And I'll start off with just thinking about what the patients say. What do patients say to us in the IBS network? I get a lot of letters from patients, and the biggest comment they say to me is, my doctor never listens to me. My doctor never listens to me. He's never got time. He tells me, you've just got IBS, you have to live with it. My doctor thinks it's all in my mind. The treatments never work, they just cause other symptoms. I'm so afraid they're missing something more serious. I must have an allergy. I'm desperate. The number of patients that write and say, I'm desperate, you're my last resort, my heart sinks, I must say. IBS is wrecking my life. Every time I go to the hospital, I see a different doctor. What do the doctors say? They're never satisfied. They seem disappointed when they have nothing serious wrong. Or as one surgeon said to me once, they're all bonkers, Nick. Whenever she comes in, my heart sinks. I treat one symptom and another one pops up. They all think they've got allergies. They're so demanding, they make me feel so angry, such a waste of my time. I'd do anything if they go somewhere else. There's a real failure of communication, a real clash of cultures there. The doctors are trained to do what doctors do, and by and large they do it really well, and that is to rule out treatable conditions, to make sure somebody doesn't have life-threatening treatable conditions. The patient's agenda is, I've got this terribly painful, disabling disease, please can somebody do something about it? There's a clash there. There's often a hidden agenda, particularly with the patient. There's often something else going on that they haven't got time to say to the doctor, something maybe in their relationship or at work or something like that. There's a failure to address the patient's concern, and there's not enough time to listen actively. In the meantime, there has been, over the last few years, an explosion in our knowledge about the gut. We know a tremendous amount about the gut. While I was training and being a psychotherapist, I sort of wasn't reading what was going on in the literature for some time. And recently, the last few years, I've come back to it and I've realized, golly, things have moved on in a big, big way. In terms of the brain-gut axis, in terms of the gut immune system, in terms of the microbiota, we know a tremendous amount. We know much more about how the gut works. But can we identify the causes of IBS? Well, not yet, not yet. A number of possibilities, a burgeoning number of possibilities, but we're not there yet. Do we know how to treat it? No, not really. Or do we know more about the means by which what happens upsets the gut? Do we know more about the mechanisms there? I suspect we do, the latter we do, but we may be getting somewhere with regard to knowing what IBS is and how to treat it. But I don't think we're there yet. Has Rome held us up? Yes, undoubtedly. I think Rome's been a disaster, I must say. I really think this has held us up big time. How can you have overarching criteria for something as broad as IBS? Why is there not more focus on individual symptoms, looking at the pathophysiology of individual symptoms? Luckily, things have changed a bit. The segregation of IBS into IBS-D, IBS-C, IBS-M is helpful. I'd like to see the same for bloating, for abdominal pain, maybe for IBS fatigue, whatever. But I think we're going to lose IBS in years to come. I think it's made it very difficult to identify subsets and biomarkers, and by and large, however much the Rome Committee may say this is a positive diagnosis, the reality is it isn't. It's a diagnosis, as John was saying, by exclusion. That's the way most doctors practice. So I don't think this exercise has been helpful. So what is the irritable bowel syndrome? Is it a disease awaiting a cause? Is it a syndrome with several causes? Is it a diagnosis by exclusion? Is it an illness invented by a committee? Yes. Is it a malaise of the individual? Yes, it's very much an individual condition. Is it a little bit like medicine used to be? I'm very interested in medical history, and you read back, 100, 150, 200 years ago, you realize that actually where we are with IBS and other unexplained diseases is where we were 150, 200 years ago with all of medicine, where, you know, almost any idea went. And there was some evidence to back it up, but we didn't quite know where we got to yet. Is it the visceral expression of the way we lead our life, or what happens? Maybe. And we're talking about illness here. So is illness different from disease? Are ailments different from diseases? I think medicine has been remarkably good at identifying pathology and treating it. It's amazing things can be done once you can identify the pathology and diagnose the disease. But it's left a whole raft of illnesses that we can't really identify. They all overlap with each other, and the treatments are variable. So this is illness, and I think what we struggle with is chronic illness at the moment in our health service. It's a major problem. So IBS is an ailment. It's a state of dysphoria. It involves the mind and the body. It's an expression of the individual. Their diet and lifestyle, the meaning of what happens. Emphasize that point, the meaning of what happens. As a psychotherapist, I'm often talking to patients with IBS about the meaning of their symptoms. And once we can get at that and start to deal with it, the symptoms seem to evaporate in many conditions, but you need time to do it. The meaning of what happens in the context of their life experience. Meaningful treatments that mean something, like giving good bugs to get rid of the bad bugs, are remarkably effective. It's tremendously good PR. Communication can heal, and cure is about motivation and change. But IBS is just too big a problem. There's 15 million people out there with IBS. People with IBS need more time and effort than people with an identifiable disease. It can mimic a lot of life-threatening diseases, so you've got to rule them out. Treatments often don't work, so you've got to try other trials of treatments. Patients are often disappointed. Dealing with other people's disappointment is very difficult. It's very debilitating for the doctors. And the doctor might say, I've not been trained to deal with illnesses like IBS. And indeed, at medical school, you're not trained to deal with illnesses like IBS. It's not the best use of my time. And it's going to get worse, because if fecal calprotectin comes on board and there's increased availability of screening tests for IBS so that less patients need to be referred up to secondary care, that will mean more patients in primary care, more IBS managed in the community. The situation for the GP can only get worse. So is this a recipe for self-management? not enough medical resource, many treatment options, confidence and belief are crucial, personalized dietary lifestyle change, the meaning what happens, etc. Is this a recipe for self-management? And self-management depends on having the confidence, having self-efficacy. We're more informed than ever before. We should use that resource. This is not a bad thing. I think it's great when a patient comes in to see me and they know what they're talking about. They say they've read this on the net or in the paper, and what do I think of this? And you can sit down and you can have an informed conversation. That's often really quite good. The patient understands how they react to things. We're all really interested in the way we react to situations and things and diet and lifestyle changes, etc. Patients understand that by and large. They also have a feeling for what can work and what can't work. So you go with the flow as a doctor very often and go with the patient's feelings when it makes sense and they're not going to cause themselves damage. Knowledge stimulates health, confidence, and improves quality of life, and it informs communication with health professionals. The patient should be, for illnesses, in control, but working in partnership with the healthcare professional. It's all about helping you help yourself better. What works for what symptoms, how diet and stress interact, understanding what your symptoms mean, what they represent, make the connection between the onset or the exacerbation of symptoms and what has happened. Learning how to self-regulate. Self-regulation is tremendously important. We did a study some years ago, and I wish it was at the time that I started studying for psychotherapy, and my then tutor in psychotherapy said, you can't do any more research, Nick. You've got to devote your time to being a psychotherapist. You can't do everything. But I was in the middle of a really interesting study, which we never got published, where we were recording people with erratic bowel habits. And we also recorded their mood, we recorded their eating habits, we recorded, there was something else, sleep patterns. There were a number of modalities that we recorded. And on every measure, those with erratic bowel habits had erratic moods, had erratic eating patterns, had erratic sleep patterns. These were erratic people. IBS is much more. We medicalize down and focus down on the gut, but actually IBS is much more than the gut, much more than the gut. So learning to self-regulate is very important. Make the changes that you need to. It's about information, advice, support, confidence and motivation. That's what self-help is about. And nowadays, people get more help on the internet than they get from anywhere else. Again, I reiterate that people are very informed. So what do patients want to know? Well, again, we developed our self-care plan, the IBS Network's IBS self-care plan, on the basis of what patients asked us. What is IBS? Is this IBS? I've got backache. I've got aches in my joints and my legs. Can this be IBS? Do I need more tests? Is it something I've eaten? Is it all due to stress? What can I eat? How can I manage my IBS? What medications are useful? Are therapists helpful? How can I cope with it all? But I don't think self-help for IBS is a matter of putting a self-care plan or giving on the website or giving patients leaflets and leaving them to get on with it. I think IBS is best managed by the informed patient, so information is important, but facilitated really in primary care or the most accessible medical environment by, ideally, in an ideal world, what I'm going to call digestive health practitioners. And they might be non-medical practice nurses, dietitians, counsellors, pharmacists, or even expert patients. We need to recruit more people who can be trained relatively briefly, probably over 3 months training, with continued supervision, can be trained to manage something like IBS or to help people manage their IBS, and supported by the charitable sector. I think the charities here play an important role. So guided self-management is what we're about. And this is about supporting, informing, advising, inspiring, motivating, encouraging responsibility, enabling understanding and connection, promoting self-efficacy, facilitating change, providing resource, bringing about a more effective and empowering therapeutic relationship. And for the doctor, instead of this tired, old-looking doctor, suddenly you have a really attractive, confident doctor and a relaxed patient, better communication and saving of time and resources in an ideal world. We don't live in an ideal world, unfortunately, but this is something we can aspire to. Has there been any research in this area? Well, not very much research in self-help, but there have been some. I picked out a few studies here. I think one of the most interesting ones was a study by Robinson, reported in Gut, 2006, a community study in 420 IBS patients in Manchester, showed that a guidebook plus self-help group meeting showed a 60% reduction in consultations, a 40% reduction in healthcare costs, and reduced symptom severity. I'm not going to go, in the interest of time, I'm not going to go through all of these, but there is some evidence there that self-help works. We should be testing our self-care plan and seeing whether this is making a difference. But I do think it needs to be done in conjunction with digestive health practitioners. So the self-care plan we've come up with in the IBS network, we've aimed for it to be reliable, independent, accessible, authoritative, and provide information, advice, and support. We've developed this in conjunction with an advisory board from all the modalities of healthcare professionals who've advised us on how to set it up, and we've taken their criticisms on board and produced something as a result of that. It comes free on your computer, so it's absolutely free, and you can get it through the website. And just flipping through this briefly, this is what it looks like. It's got a number of sub-menus there. Have I got IBS? Diet, stress, medical, therapies, and then my IBS, constipation, diarrhea, bloating, abdominal pain, and finally something you can fill in yourself, which is a symptom tracker, to track your own symptoms and plot what difference life events or treatments make. This is the page, what is the cause of my IBS? Is it food intolerance? Again, you click on any of these bits and it leads you into sub-menus, as you would expect. This is the stress side, reducing fear and panic. Often there's a patient story in there. You can click on that and get the patient's story. Acupuncture, this is complementary therapies. What causes bloating, my IBS? And devise your own self-care plan where you can actually interact with it. But this isn't the only thing. I mean, we are aware in the IBS network that providing a self-care plan, I think, is useful. It just needs to be tested now. More people need to be aware of it. More patients need to use it. More healthcare professionals need to know about it. But people can also join up and become a member. They can write and get professional advice by email. At the moment I answer the emails, and it hasn't completely overwhelmed me yet. There's a telephone helpline, a symptom tracker, a quarterly magazine, monthly newsletter, etc. And can't wait cards. People really like the can't wait cards. This allows them to gain access to loos in offices and stores where they might otherwise struggle. And that's just for £24 a year. That's all I have to say. Thank you for your attention.
Thank you very much, Nick. As a GP, I greatly appreciate all of this. And patients, I know, scour Dr. Google to know what to do for their symptoms. And it's good to be able to give them a specific site that we can trust to give good information. Do we have any questions?
My name is Anna. I work in a CBT service, and we get a lot of patients with IBS and stress symptoms, and I haven't worked with them on a deep psychological level yet, but I was just wondering how, because I can advise them to do self-support. We work with, obviously, CBT is based on helping themselves, but I just wonder if there's anything you can, if you can talk a little bit more about the psychological link to IBS, and you know, just give us a bit more insights on how to talk to patients and how to give more psychoeducation to them.
Okay. Well, what I tend to do, I mean, I must admit, when I see people, I'm reasonably privileged because I've got time, but nevertheless, I also have done the telephone helpline where literally I'm having to respond within about 8 minutes. So very often I find I listen to the patient's story, I try and ask them to be reasonably brief about what's going on, but I listen to their story and then pick up on cues, because very often they will tell you what's actually happening. I mean, the person who says, oh, I'm desperate, I'm absolutely desperate about this. Often you can say, well, what are you desperate about? What's happening? I can understand the symptoms, but what's happening? And they will often say, oh, you know, it's making my life hell. I just am snappy with the children, not getting on with my husband, you know. Or they will be other things like, you might say, well, when does the symptoms come on? Oh, I get them every Monday morning. When you go to work, you mean? Yes, whenever I sit out, I get this awful pain and things like that. It starts a dialogue, you see, that you can then start to explore. I'm not saying it's all psychological, but the brain-gut axis is very active, and at least with diet and stress, you can start to do something about it. You know, the patient can start to gain insight and do something about it, and that's what you're trying to get at in self-help. You want to get to where the patient can start to see and understand and be able to do. And then it's very rewarding, because next time they come back, they say, well, you know what we talked about last time, I've done this now, and actually it is better, but I was wondering about this. You start getting along a trajectory. But time is always the enemy. You know, for busy GPs, I think I'm lucky I just focus on IBS most of the time, but I do other things. John?
Just a quick comment, Nick. When I started in gastroenterology before the war, we used to refer to IBS as psychosomatic illness. I think the problem in primary care now is so afraid of actually talking about psychological problems and stress of life that we've used all the data of the gut axis and all the rest of it, and gut problems and microbiota, etc., and that's what GPs like to talk about. They never like to talk about the stress side of things, in case a patient thinks, so you think it's in my head. And countering that, is it in my head, doctor?
Yeah.
It's a really difficult thing to do in 10 minutes.
It is difficult, John. I don't deny the difficulty, and that's why I try and get the patient to start talking about it, so they're giving the lead, and then you can go on from there. IBS, I find IBS patients are easier to talk to than patients with chronic fatigue syndrome. I really worry for my life sometimes.
I'd just like to follow up on trying to get some of the background of what's going on in the patient's life. Yes. And I found a really easy way of doing that is if you say to them, what would you give your job out of 10 if 10 is good and 1 is bad? And immediately they say, oh, it's -1. This is a real problem for this person, and it's probably what's making them ill in the first place. But it's a really quick way. Yes. You can apply it to their partner, their childhood, their job, and it's quite a good way in to finding out what else is going on in their life.
Thank you. That sounds good.
I just wanted to follow that up. I'm a dietitian in secondary and tertiary care, and we have an absolutely cram-packed gastro clinic, and it seems that I'm the only one who has enough time to talk to them, not through criticism of my colleagues, just because they're absolutely overrun with patients. I wondered if we actually need to go back to grassroots and change our practice, just make slots longer. It may take us longer to get through patients, but maybe you just need to start listening at the outset. Following up what this lady said, I had one lady in my clinic room, IBS, blah, blah, blah. By the time I was chatting away to her, and she said, well, of course, the colonoscopy was awful. And I said, oh, why was that? She said, well, of course, I was sexually abused. And actually, the IBS started up the very same month, and I had asked her in a very discreet way so as not to cover the two. And the consultant who'd referred that very afternoon wasn't aware of that. And again, that's not a criticism of the consultant, it's just the scenario. Maybe we're missing out the obvious stuff, which is just how we structure a clinic.
Yeah. Yeah, I think that's great. Thank you for that. I think that's really useful insights, and I think many dietitians, other healthcare professionals, doctors, they will have similar insights, but there just isn't time. I know I've talked to doctors, and they've said, well, quite honestly, I can't get into this. Emotional stuff. It's going to take me all clinic. I just don't want to go there, and it's difficult. But I think, if you're a dietitian and you're dealing with, you've got a treatment, which is a good treatment, a low FODMAP diet is very, very useful. But very often, what you're dealing with, as Peter Gibson has explained in a recent review, is that you're dealing with the sensitive gut that responds to fermentable carbohydrates. And don't forget the sensitive gut, because the gut is often sensitive because of what's happened. And I tend to work on the principle of food and mood. Think about the food, but also think about their mood and what's happened, or what have happened recently in the context of their previous history, maybe difficulties in childhood and things like that. But it doesn't take very long to begin to get to the stress, mood side of it, and the two interact. And often if you just give a low FODMAP diet without going into that, you don't do the whole thing. You miss out. So I would really make a plea for many dietitians to have this digestive health practitioner training, so at least they feel reasonably confident about listening to the emotional stuff, even though they don't want to go in there and advise.
Thank you, Nick.